I'm passionate about changing outcomes for patients, and I think the one enormous neglected area are the generality of GI symptoms that happen in patients when they go through cancer treatment. There has been fantastic development in treating nausea and vomiting, but still 1 to 5% of patients having chemotherapy will die as a result of diarrhea, with or without neutropenic sepsis. And what we do about that diarrhea and why patients get chemotherapy-induced diarrhea, the research is almost non-existent. Secondly, many of my patients in our specialist clinic where we see consequences of treatment tell me that as they go through treatment they have horrible times. They get from one end to the other and they're incredibly grateful to the oncologist who has saved their life, but they often say to us as a multidisciplinary team looking after side effects that we have given them their life back by dealing with these difficult symptoms. So for me, one of the most exciting things is because MASCC is the only organisation which cross-cuts and is really interested in supportive care, is to come here and emphasise how important GI symptoms are, the progress that has been made in understanding why they happen, and to start to tell people about things which can be done. And also a call to arms to say that this is an area which has been largely forgotten, and while we've become brilliant at pain control, while we're brilliant at stopping nausea and vomiting, actually bloating, wind, diarrhea, incontinence have been forgotten. The first thing we've done is we've shown how commonly these things happen. And they're incredibly common. And they're incredibly common with lots of treatment modalities. The second thing we've done is we have shown how you can approach the symptoms that patients get. And if you do it in a very systematic way, it starts to become very easy to break symptoms down into their kind of component parts. And then the third thing that we've spent a lot of time demonstrating is why people get symptoms. And there's a real misunderstanding that the drug causes the symptoms. The drug doesn't cause the symptom. What the drug does is it affects the GI physiology, and because the GI physiology is affected, that causes the symptoms. And we can treat the physiology, and so we can improve symptoms. And that has been, I think, an important conceptual advance, which is useful for people to meet. And the fourth thing I think that I've really enjoyed doing is demonstrating how at the Royal Marsden, how I work as part of a bigger team, the oncology team, that actually it complements them. And I've tried to emphasise how units need to try and develop this expertise in their gastroenterologists, who have been a little bit slow to say that this is an interesting area to work in. We've shown that in our trials, that our patients tell us that by our interventions, and these are patients groups which are told that nothing can be done about their symptoms, that we can improve things by 70 to 90% by doing things in a very standardised way. So we don't sort it out completely, and there is a cost to being treated or cured of your cancer, but to do nothing is also wrong. So my message is one of real hope that quite simple things can really change the outcomes for patients and can change the outcomes for oncologists, because it means that they are very likely to be able to deliver their treatments in a much more efficient way with far fewer side effects and problems. There was a very interesting editorial or opinion piece in the Journal of Clinical Oncology earlier this year, which said that there is a crying need for a new specialty of oncogastroenterology. And that's what I am. I'm a supportive care doctor, but with a real specialism as a gastroenterology in people having cancer treatments. And it's not somewhere where gastroenterologists should dabble, because it's complicated and it's scary and people get problems quite different from those with benign gastroenterological diseases. But without your oncogastroenterologist in your unit, you're going to really struggle to manage your patients to the best of their ability.